During my presentation, we talked about comprehensive care. We talked about how to manage risk associated with the various medications available. We had some very lively panel discussions about symptom management, pathogenesis of MS, and throughout the meeting here for the last couple of days, we've been investigating primary progressive MS. We were looking at all forms of MS. There was a lot of conversation about what we can treat currently, with the hope that we're going to learn more and be able to come up with ideas and therapeutics for the progressive form, but unfortunately we have yet to figure that out. Well, we have to determine what we believe to be the best therapy for an individual patient. The disease is very heterogeneous, and you hope that you can select a medication that's going to control their disease while giving as best we can do, a lower risk profile. We don't have any way to figure that out at this point in terms of, who's going to develop any adverse reactions to the medications. But we want to take the approach of safety and balance that with the efficacy. And to the best of our appreciation, as we've gone forward over the last several years, we're getting better at the efficacy arena of treatment, but we are accruing a whole new safety profile that can be problematic. So it's a risk-benefit conversation with the patient and figuring out what their tolerance for the risk is and what we believe the best efficacious drug should be. Yeah, that's a big challenge because some of the medications that we use to treat MS do have significant side effects that can make their symptoms worse. And some of that might include, flu-like symptoms that might increase their pain levels or their spasticity levels, or certain medications you have to have, frequent monitoring. But, I think when we talk about which medication we want to use for a patient, education being the primary discussion so that they understand what the medication is supposed to be doing, they have realistic expectations, and in addition to that, they understand what the potential side effects are. And we let them know that if they take this medication, they may experience a little of whatever these other symptoms are, and we have ways to mitigate that, whether it be, putting them on an additional medication, or whether or not we need to just kind of a dose adjust. I mean, there are a variety of things we try and do to keep that patient happy and not accrue new symptoms that they didn't want to have. Absolutely. So, one of the big issues with some of the newer medications is they can have other systemic type of safety concerns. So as you get older, you may, have other medical issues, comorbidities, and we look to see if a certain medication or class of medications may be not appropriate for that particular patient because of what their comorbidities are. Age doesn't seem to play a huge role in the decision process about which medication we should be using necessarily, but we know that as you get older, there might be an increased risk for certain other conditions like malignancies or things like that. And if there are drugs that have maybe a small signal in that arena, we may choose not to put them on something like that. I think the MS community overall, physicians feel fairly comfortable with the older medications that are available, and that usually is their go-to when a new drug comes out. Now, some patients will drive the conversation of, this new drug, and maybe they failed all these other drugs. But we'll never have long-term safety data for any of these new agents as they come to market. Now, if you have a drug that at least in the clinical trials did not show up with any new major safety signals and people feel fairly comfortable about using it, we do. Some of the challenges we face is that sometimes the insurers and the payers don't want to actually allow us to use these because they may be coming in at a higher price point, and they want us to go ahead and do a stepwise treatment algorithm, which can be frustrating because if somebody has failed some of these other medications and you want to put them on this and the insurer doesn't want to actually allow you to do that, very frustrating both for the patient and the physician. A lot of times we end up having to write a lot of letters, make phone calls, talk to the medical directors at various insurance companies, And most of the time we can get that through if we push hard enough. But you can imagine if you have a small number of patients, probably not a big deal. If you have a huge center with thousands of patients and you have to do this on an ongoing basis with every single patient you want to prescribe the drug, it becomes very cumbersome.